New mental, behavioural and neurodevelopmental disorders in the ICD-11. Here we will discuss intermittent explosive disorder and body integrity dysphoria. 6. C73, Intermittent Explosive Disorder. Intermittent explosive disorder was introduced in the DSM-3R. It appeared in the ICD-10 only as an inclusion term under other habit and impulse disorders. It is included in the ICD-11 Impulse Control Disorders section in recognition of the substantial evidence of its validity and utility in clinical settings. Diagnostic requirements of intermittent explosive disorder. A pattern of recurrent, brief, explosive episodes involving verbal aggression, for example, verbally attacking another person, temper outbursts, yelling, or physical aggression. In an individual who is at least 6 years of age, when inhibition of angry outbursts is expected to have been attained, or equivalent developmental level. Episodes of physical aggression may result in significant damage or destruction of property or physical assault involving personal injury. However, such outcomes are not required for the diagnosis. The intensity of the outbursts or the degree of the aggressiveness is grossly out of proportion to the provocation or precipitating event or situation. The explosive outbursts must occur regularly over an extended period of time, for example, at least 3 months, so as to represent a persistent pattern of aggressive behavior. A lower frequency threshold, for example, several times over the course of a year, may be used for high-intensity outbursts with serious negative consequences, such as physically assaulting another person. Whereas a higher frequency threshold, for example, 2 or more times per week, should be used for episodes characterized by verbal aggression or non-assaultive and non-destructive physical aggression. The aggressive behaviors are clearly impulsive or reactive in nature, and represent a failure to control aggressive impulse. That is, the aggressive acts are not planned or instrumental in achieving a desired outcome. 5. The frequency and intensity of explosive episodes is outside the limits of normal variation expected for age and developmental level. 6. The explosive outbursts are not better accounted for by another mental, behavioral or neurodevelopmental disorder, for example, autism spectrum disorder, attention deficit hyperactivity disorder, oppositional defiant disorder with chronic irritability, anger, conduct dissocial disorder, delirium. 7. The explosive outbursts are not due to the effects of a substance or medication on the central nervous system, for example, amphetamines, including substance intoxication and withdrawal, or due to a disease of the nervous system. The behavior pattern results in significant distress for the individual with the disorder or significant impairment in personal, family, social, educational, occupational, or other important areas of functioning. Additional clinical features of intermittent explosive disorder. Explosive episodes may be associated with affective symptoms, anger, irritability, rage, during aggressive outbursts. Sometimes the aggressive episodes are preceded by premonitory symptoms, such as tremor or chest tightness, or a more general feeling of tension or arousal. 2. Explosive outbursts in intermittent explosive disorder are typically triggered by perceived threats in social settings, even when there is no real threat but, for example, based on an inaccurate attribution of hostility to others, or by frustration when facing obstacles in the course of daily life. 3. There is a wide array of aggressive behaviors that could fulfill the requirements for intermittent explosive disorder, ranging from verbal aggression to physical assault, and destruction of property. 4. After the explosive episode, the individual often, but not always, experiences depressed mood or fatigue, or other negative emotions such as regret, remorse, guilt or shame. Some individuals with intermittent explosive disorder exhibit nonspecific abnormalities on neurological examination, for example, soft signs, and electroencephalographic testing that do not constitute a diagnosable disease of the nervous system. In the presence of such findings, intermittent explosive disorder may still be diagnosed if the diagnostic requirements are met. 6. Many individuals with intermittent explosive disorder have a history of exposure to traumatic events, witnessing violence, or childhood physical abuse. 7. Intermittent explosive disorder often co-occurs with depressive disorders, anxiety or fear-related disorders, disorders due to substance use, and eating disorders, especially those involving binge eating. Boundary with normality. 1. Aggressive outbursts, particularly verbal ones, are common, especially when the individual is under stress, and are not in themselves indicative of psychopathology. Course features. The mean age of onset of intermittent explosive disorder is between 10 and 16 years of age. Age of onset is typically earlier than common co-occurring disorders such as depressive disorders, anxiety or fear-related disorders, eating disorders, and disorders due to substance use. Intermittent explosive disorder tends to exhibit a persistent course over many years. 2. Aggressive behavior in general tends to diminish over time, and the prevalence of intermittent explosive disorder correspondingly diminishes over the lifespan. Developmental presentations. Early in the course of intermittent explosive disorder, children typically display temper tantrums associated with verbal outbursts and aggression against objects, though typically without serious destruction of objects or assault against others. During adolescence, explosive outbursts often escalate to include destruction of objects or property or physical assault against others. Culture-related features. 1. Variation in prevalence of intermittent explosive disorder may be related to cultural norms regarding emotion regulation. Moreover, clinicians may misattribute anger to a single triggering event, when it is in reaction to the accumulation of multiple environmental stressors, for example, discrimination, losses, displacement, limited social support, powerlessness, and injustice. Sex and or gender-related features. 1. Although it was originally believed that intermittent explosive disorder was much more prevalent in males, recent community surveys suggest similar prevalence rates by gender. However, serious physical assault is a more common manifestation of the disorder in males, whereas less serious physical and verbal aggression is more characteristic of females. Please subscribe and comment.